So welcome to our third lecture in this series in 2022. I'm Annie McCluskey. I'm an occupational therapist and one of the StrokeEd collaborators. And today it's a good pleasure to introduce Dr. Tam Levy, who's in Adelaide in South Australia. I'm currently on Arente land in Alice Springs in Central Australia, quarantining with COVID. But fortunately feeling a little bit better today. So Tam is going to tell us a little bit about her PhD research. She's a physiotherapist who works in neurorehabilitation, and her PhD, which she completed last year, explored the adherence to intensive upper limb exercises. And as I said before, for anybody who's just joined, please put any questions you might have into the Q&A. And we'll have regular breaks as we go along. The recording of the presentation will be available on our StrokeEd website within a few days, and you can find all of our recordings under the resources section. If you go to our website and look at the top of the web page, you'll see there's a tab called resources, and our lectures and recordings are stored there. There is no handout made available with this presentation. But Tam will stop when you have references at the end, so you can take a photograph if you wish to do that. So I'll pass over to you now, Tam.
Great, thank you, Annie. Thank you to Annie and the StrokeEd team for inviting me to present to you today. And I'd like to thank you for joining from the corners of the world. That was quite an exotic list that Annie read out. It made me want to get on a plane and do a bit of travel, but I appreciate that some of you probably are not the most convenient as far as time zones, and I really appreciate the effort made to come and listen to me today. So the title of my presentation is just that four-letter word, hope, stroke survivors' perspectives of participating in an intensive upper limb exercise program, and it was a qualitative exploration. And I'd like to start by thanking my fellow authors on this research. Oh, sorry, my screen's frozen. That's not a good start. There we go. So firstly, I'd like to acknowledge that I'm currently on Kaurna land, and I'd like to pay my respects to elders and ancestors past, present and future, and recognise the continued connection to the land and waters of the Flinders University's beautiful teaching locations. Just to introduce myself a little bit before I get into the presentation. So I studied in Adelaide and graduated a long time ago. And I've been working in neurological rehab for over 30 years now. I still currently have a clinical role. So I work in a hospital, Flinders Medical Centre, in the rehabilitation services, as Annie said, in Adelaide in South Australia. And as well as that, up the road, there's a university where I work now in a balanced research and teaching role. When I was working as a clinician, I started a master's, which I upgraded to PhD. And as Annie said, that was conferred last year. My ongoing research interests are around stroke rehab and evidence-based practice and adherence, and particularly more and more so behaviour change. So that was something I became really interested in through a couple of my PhD studies. And last November, I completed the behaviour change week-long course from University College of London, which was amazing. It was a very immersive experience. It was with Susan Mickey and her group, who are the developers of the behaviour change wheel. So it was a week-long course, and it was really beneficial. It was challenging for me because it was from England, so I was up to 1 a.m. every day, but it was something that I really, really loved. So the objectives for today are to gain an understanding of the key barriers and enablers to intensive exercise in stroke survivors, to gain a basic understanding of the role of the COM-B, which is a behaviour change model, capability, opportunity, motivation, in exploring stroke survivors' behaviour. And this will be of interest, particularly if you also have a little bit of a research interest and are interested in qualitative research. and to understand the importance of well-designed, individualised exercise programs. So that's going to be of interest to you, obviously, if you're a clinician as well. Hopefully you'll get some tips around how to develop programs which might be more motivating for the stroke survivors and hence lead to improved adherence. So some of the take-home messages. So remembering that hope is really important for stroke survivors. Thinking of ourselves as coaches and supporters for ongoing motivation. Consider whether the timing is right for participating in intensive programs. Ensure the stroke survivor can actually do what you're asking them to. We should consider the use of contracts, behavioural contracts, and also think about how much support, social support is available, not just how much, but who it is and what they can offer. This slide is just showing an infographic. So at the end of this qualitative study, I developed this infographic, mainly for the health professionals that I work with. So obviously you can't see the detail in the text there, but I believe that this is being shared on the StrokeEd platform. But you can see the general gist of it with the capability, opportunity, and motivation, which I've already mentioned. These are themes that we'll run through the presentation today. So we know that many stroke survivors don't end up with a functional, useful upper limb after a stroke. And unfortunately, that really relates to poor, reduced quality of life. We have very strong evidence that to drive recovery, stroke survivors should be doing as much practice as possible. And when we think about how much that actually means, Emma Schneider in her systematic review and meta-analysis had a look at that. So she looked at how much extra rehabilitation of the same sort was needed in order to achieve a benefit. And it's actually a huge amount. It was 240% increase, which really in practical terms means that if your usual dose is 30 minutes, they need to increase that to 100 minutes to be able to reach that threshold. So it's a lot more practice. And we know that that's challenging in the rehab environment. So we need to be clever and creative and think about innovative ways to increase practice. So when it comes to stroke survivor adherence, there's been quite a bit of research on that. And it's often reported to be quite low, particularly around 6 months. Yo did an interesting study. So he looked at, he used a questionnaire and he looked at stroke survivor adherence from weeks sort of 2 through to 24. And he identified 3 main phases. So the first phase was sort of between weeks 1 and 6, and he referred to this as the rapid increase phase. So this is obviously when most people are in hospital, they've got a lot of support from health professionals, and they're also in that phase where they're getting more of that kind of neuroplastic type improvement. From about week 6 to 21, they identified a slow decrease phase. And that often linked to when people had gone home or left the hospital. So they were obviously having less involvement with the health professionals, being left on their own devices a bit more. And then after 21 weeks, they talked about a stable phase. So this was when they're sort of accustomed to the lifestyle and the rate of recovery had slowed down a little bit. And I identified this as a phase where new health problems can potentially occur. They also identified factors that they thought were relevant in leading to these phases. And they were things such as willpower, which really means motivation. So there's a lot of evidence that says the biggest factor in relation to adherence is motivation. They talked about whether the person had success or failure and how that had a role, and also social support. I think the other thing to really be thinking about in relation to adherence is that there's now more of a focus on these home-based programs. And obviously with COVID, that's become more and more relevant. But unfortunately, the evidence says that many stroke survivors aren't adherent to home programs. So we need to think about, are we doing enough to support them to participate in home programs at an intensity that's needed for them to achieve benefits? So there've been limited research really exploring this, which is where I went with my PhD. So the aims of this study were to look at what was the experiences of people participating in an intensive upper limb exercise program, and what were the factors, what were the barriers and enablers to participation. So it was a qualitative study, and we did semi-structured interviews with 20 participants from the intervention arm of the INTENSE trial. So the INTENSE trial, which stands for Intensive Therapy Efficacy After Neurological Spasticity Treatment, was an NH and MRC funded multi-centre trial, which looked at whether the addition of 3 months of evidence-based movement training was more effective than usual care in people who have had botulinum toxin injections in terms of their goal attainment and upper limb activity, which was measured with the box and block test. So they did, the primary outcome measures were goal attainment scaling and box and block test. And they did that at 3 months and at 12 months. So who were they? Well, there was 139 participants, and the mean time since stroke was over 3 years. So they would be considered a chronic group. As you can see by the range there, we really did have a very wide inclusion for this study. So the range was from 0.3 up to 43 years. So many of these stroke patients had not had any intervention for a long, long time. They also were quite a chronic population in terms of what they could do. So the average using the box and block test was 2 blocks, whereas the age match is about 70. And nearly 80% of them actually couldn't move any blocks. So what they did, so the trial had a control and an intervention group. Both groups received botulinum toxin A injections to muscles that cross the wrist. The control group then received a sheet of exercises, and they also received a follow-up phone call to see how they were progressing. The intervention group had 2 weeks of serial casting, and that was sort of in maximal wrist extension. So we pushed them as hard as we could get them, and they generally had 3 casts in that 2 weeks. And then once that cast came off, they did 10 weeks of movement retraining. So that was dependent on how much activity they actually had. So there was sort of 4 levels, 0 being E-stim, and then 3 levels of motor practice, which was based on the GRASP program. They were asked to practice at home for an hour every day for 10 weeks. So a total of 70 hours of practice. And that was supported by centre-based sessions. So they would come in at the start of the trial, they would come in a couple of times a week to see the therapists. And that sort of reduced as the trial went along. So you can see in some of the photos here, these are just little photos of some of the participants. So starting at the top here, this gentleman's obviously using the E-stim. Then there's some activities in the GRASP program using blocks. This lady here is using one of the weights. So there's a range of exercises in the GRASP program. This gentleman here is doing the reaching towards the target exercise. There's also some whole body and upper limb stretches, which you can see here. And then this is just an example of a younger stroke survivor who had a carer to help her with her exercises. So self-report adherence. So everyone in the trial was asked to record how much practice they did in terms of time. And self-reported adherence was high. At the start of the trial, they were reporting that the mean was about 52 minutes, which is 87% of what they were asked. And even at the end of the 10 weeks, they were doing about 37 minutes, which was 62%. Now, we know there's some issues around self-reporting in some populations, but we did have, as one of my PhD studies, I did a feasibility study with 10 of these participants, where I set them up with a iPad in front of them, and they were sitting there doing their exercises whilst it was recording. So we were looking at the feasibility of using a tablet computer, an iPad, to monitor practice. So for those 10, we had objective data from the iPad, and the mean exercise time was 50 minutes. Again, there was quite a wide range. But what we found, the INTENSE trial results were at the time pretty surprising. There was no difference in primary outcome measures. And the only difference that favoured the experimental group was this in strength. But we kind of felt that as we were doing the intervention. So we sensed that some of the participants would come in with, tightly fisted hands with contracture and spasticity. And we could sense that whatever we were throwing at them, they weren't making, changes that might be significant in terms of their goal, or certainly their ability to move a block. But on the other hand, the ones who were sort of had more activity and could do more were really loving it and were getting a lot from it. So that was the group that we found were really responding. So we thought they were a really interesting group to talk to, because they weren't really changing a lot, but they still kept going. And that was like, well, why did you, what drove you to keep practicing? So as I said, the exercises were based on the GRASP program. So that's the program out of the University of British Columbia, which is all available online, and there's different levels and different exercises. Now, I've just got a little video here of one of our participants. He was a bit of a rock star participant. He was one of our real good ones. So I'll just run through some of the exercises he was doing. Oh, sorry. Okay, so that's just a range of the exercises in the GRASP manual that he was doing at home. Anyone might stop there. I'm not sure if there's any questions, but it might be a good place to have a little pause.
Yes, Tam, there's a couple of questions for you. The first one is, can you explain a little bit more about the need for the 240% increase in rehab? And I've put a link into Emma Schneider's systematic review from the Journal of Physiotherapy.
Yeah.
So people can understand what you mean by 240% increase.
Yeah, so I would suggest having a read of that paper, but she did a systematic review and meta-analysis where she looked at the addition of the same content of therapy, but in addition to what usual care was. And she found that when there was a big increase, for example, over 100% extra, they were the ones that tended to improve the most. And her overall summary, I'd have to read the science behind how she came up with the figure, was 240%, which, as I said, literally means more than triple what their usual care is. So if they're doing 30 minutes, then they would have to then do 100 minutes to achieve the benefit.
Yeah, that's right. So she included I think it was 18 randomized trials of upper limb and lower limb rehab in stroke. People who had a stroke, and the studies where people had benefit, as in greater outcome for their walking or their arm. They had done at least triple the amount. They had done triple the amount of practice of the same exercise.
Yeah.
So the second question is, there's somebody in Sydney asking about access for patients to clinics or outpatient follow-up for botulinum toxin and serial casting. So if anybody in Sydney, this is Sydney Southwest, wants to comment on the options, I know that people, I think at St. Joseph's Hospital in Auburn can access that kind of a clinic. I'm pretty sure Liverpool Hospital may have that clinic as well, Rachel. So if anybody else in Sydney would like to comment on what the options are, put that in the chat. So botulinum toxin, serial casting, and quite a few of the rural hospitals have botulinum and serial casting follow-up clinics. Now we have one other question. What was the outcome of the INTENSE trial? And I think you're going to talk about that in a minute, aren't you?
Well, I've kind of mentioned that. So, like as I said, in relation to the primary outcome measures of goal attainment and box and blot, there was no significant difference. The one significant difference was in terms of strength, and that was in favour of the experimental group. So that was really the only significant difference. But I think that there's been a lot of discussion around this, and I've heard a number of the primary investigators talk about it. And I think the issue is the population was so chronic that the intensity came a little bit late for many of them. That, you know, the issue of timing of this sort of intervention is something that's really important. So like I said, patients like this gentleman who had some activity and could really get into the exercises, they really improved, whereas the really chronic, you know, ones with a hand contracture and, you know, much further down the track, we weren't getting the changes that we kind of were hoping for, because, you know, for that group, there's not a lot.
Yeah. The person was asking for the reference. I'll put that in the chat.
Yeah, and it's on my reference list. Yeah.
So it's Natasha Lannon and colleagues, and it's the INTENSE trial. So I'll put that link for you. Yeah. And it's just a note for Rachel's benefit that Liverpool Brain Injury Clinic does have a clinic that you should be able to access if you're still at Fairfield Hospital, Rachel. So I'll let you continue on. Thanks very much for answering those questions.
Great, thank you. So looking at methods, so like I said, this was a qualitative study, and the really important thing is that you have sort of a strong framework to support your research and follow rigorous methods. So we developed an interview guide. As I said, we interviewed 20 participants, and that was based on the trans-theoretical model of behaviour change. So this is another behaviour change model, and it's the behaviour change model that talks about how ready people are to make a change. So it has distinct stages of readiness, such as contemplation, right through to action. So it was a sound model to use to develop the guide. And then we did the interviews, which happened between sort of September 2018 and July 2019. They were about 40 minutes each. Once those interviews were done, we sent them off to be transcribed, and then we put the transcriptions into a data management software which is used a lot in qualitative research called NVivo. And then we started the process of thematic analysis. So the first step that we did was doing some coding. So coding in thematic analysis is really when you're sort of labeling and organizing your data into themes and looking at relationships between what you're finding. We did double coding for 7 of the 20 interviews. So that double coding is an important part, again, of qualitative research. So it means that it's more rigorous, but also, you know, my experiences and knowledge might be different to the other coder, and so it makes the data analysis a little bit richer. So myself and Lauren Christie, who actually got her PhD today, which is fantastic, we coded 3 of them together, and then we independently coded 4, and we came together. So we essentially double coded 7 out of the 20, which is well and truly good practice in qualitative research. So once we'd done, so this is described as sort of inductive research. So inductive qualitative research means you're starting with your data and you're developing a framework or a theory as you progress. Once we'd done that initial thematic coding, we then used the COM-B model and we mapped our findings onto the COM-B model. That will become a little bit more apparent as I talk through the results. So we did that for the 20 interviews. So a little bit of discussion around the COM-B model. I've already talked about it a few times, and yes, I do actually quite enjoy it. It's a really great little model. So I chose this because I did a lot of exploring of different behaviour change models, and I just found it to be a really simple starting point. Simple, but also grounded in a lot of really good evidence and theory. So it was very sound. So the behaviour change wheel here basically was a synthesis of 19 behaviour change frameworks from a systematic review developed by Susan Mickey and her colleagues. So in the middle of the behaviour change wheel, the little black part here, that's the behaviour we're interested in, which for me was adherence. And then surrounding it is capability, opportunity, and motivation, all which have two components, which I'll run through in a sec. Now, around the capability, opportunity, motivation in the red here are what we call intervention functions or options. And these are sort of the broad categories of things that we can do to bring about a change in behaviour. And then further around them is what we call the policy categories. So, for example, if you were implementing a big behaviour change project into a rehab ward, you would need to be thinking about some of these bigger picture things to support your intervention. So as you can see, the COM-B is sort of the hub of the behaviour change wheel. And you can see over here on the left the relationships between these components. So capability, opportunity, they all three influence behaviour, but they can also influence motivation and bring about a change in behaviour. So the behaviour change wheel is really saying that for behaviour to change, at least one of these needs to change. And we can, it's really great for applying to stroke survivors, but it's also great when you think about your own behaviour. So I guess one of the common ones that many of us have is, you know, my goal is really to get to the gym and get super fit. So I'm very capable because I've done it before. And I've got the opportunity because I've got time and I've got shoes. But I just can't be bothered. When I get home, I'm not motivated. So you can see what needs to change there, as opposed to, you know, I'm really capable. I've got my shoes, I've got my gym bag. I'm super pumped and super motivated, but I'm working such long days, I just can't get to the gym on time. So it's a neat little model to be able to apply to stroke survivors' behaviour, but also our own behaviour as well. So as I said, the three main components of the COM-B model, capability, opportunity, motivation, all have two parts to them. So capability talks about physical capability, that's quite obvious, and psychological capability. So that means sort of, do I have the capacity to engage in the necessary thought processes to bring about a change in behaviour? You know, can I reason it through? Can I think it through? Opportunity is around physical opportunity and social opportunity. So social opportunity is more, you know, things like, well, what do other people think? What would be their opinion of it? And motivation is described as reflective, which is really thinking things through. What are my intentions? What are my beliefs? And then automatic, which is more about the sort of emotional aspects, the impulse behaviours, the habit behaviours. So it's a nicely, really nice, neat little model. And it's a really good starting point for thinking about behaviour change. So as far as results go, so you could see here, this is the demographics of the 20 interviewees. And you can see we had lots of men, which was interesting. But you can see here how they were reasonably chronic. So 75% were more than 2 years post-stroke of the 20, and half of them were more than 4 years. And then here, 13 of the 20 were doing the e-stim. So 13 of the ones we were talking to didn't have enough hand movement or even arm movement to participate in sort of more active exercises. I know that certainly in some of the dosage and intensity conversations, there's a lot of talk about repetitions. They weren't asked to record reps, but for the ones that I was looking at from my feasibility study, I had the iPad recordings and I did record reps. So for that little snapshot of 10, you can see here when they were able to move, they were doing more. So, you know, the ones at level 2 and level 3 were sort of up at 250, 300 reps in the hour. So what were some of the barriers? In relation to physical capability, the exercises were really tailored for each of the participants, but still some of them said they were just too hard. So a lot of the exercises were very difficult for me to do. There was a couple that I would skip because they were too hard. Pain, and that was often sort of pain related to the stroke rather than specifically to the exercises. But if people had pain, they really didn't want to practice as they were asked to. Reliance on others. So this was interesting because like this quote, after I've tried it, the carers come along and mend where I've stuffed up. I always need carers to help me initiate them. So some of the stroke survivors were saying they needed their carer to remind them, other people to motivate them, and other people to physically help them with the exercises, whether that was popping the e-stim electrodes on or getting the equipment for them. And that really, for some of them, was a bit of a barrier because they felt like they were burdening their carer. And that kind of differed a little bit depending on who the carer was. So, for example, some of the younger stroke survivors who had sort of paid carers, they sort of felt okay about it. Whereas, you know, if you had the older stroke survivor whose partner was trying to also do all the housework and take care of the bills and help with the showering, they just felt like they just have got enough on their plate, like I don't want to burden them. And fatigue, we know how common stroke survivor fatigue is. I remember one gentleman just saying that he was just bombed. So he said it a couple of times, I was bombed. And that was sometimes physical fatigue, but often it was also mental fatigue. In relation to the physical opportunity, so as I said earlier, at the top end of the program, people were coming in to see the clinicians, the health professionals. And many people loved that. That was really important, but probably more for the people who were living in a rural, a bit of a distance from the hospital. They found that a bit harder. And again, that kind of linked into the burdens. They couldn't drive anymore. They needed their partner, their friend to drive them. And that they found they felt bad about that. Feeling frustrated. So I get frustrated because I can't do it. I know my hand won't do it. I think, well, why should I do it? And this gentleman, I remember telling me that a number of times he sort of got a block and just threw it against the wall because he was so annoyed. So this was sort of frustration about not being able to do the exercises, but it was also expressed by a couple of people as, I'm just trying so hard and I'm not getting better, so I'm finding that frustrated. And I think this frustration plus also feeling like the exercises were too hard really links into some of the concepts around motor learning and the optimal theory of Gabrielle Wolf, which talks about the fact that we need to succeed to stay motivated. And also we tend to act when we have an expectation that we're actually going to get some benefit and have a positive outcome. So success is really important. Fitting it all in was interesting. So sometimes we didn't do it because 60 minutes because we were busy. So 60 minutes for some people was a lot and they couldn't do that every day. And it tended to vary a little bit. So the people who were really early in their stroke journey, they might have had lots of other commitments and they found it harder to do the 60 minutes. Whereas the ones who were further down the track, hadn't been doing any rehab anyway, they found it a little bit easier to fit in. But of course, the timing of the program, you know, if we leave it too late, then have we lost that window of opportunity? So what about the enablers? So what made it better? So persistence. I was constantly amazed by what people were able to do, even though they weren't changing. So just this amazing persisting attitude, just keep going no matter what, just try harder, try harder and maybe you'll get some benefit. So they seem to have this, many of them seem to have this internal drive. And yes, they had agreed to participate in an intensive program. So you would maybe expect that. Others did struggle when they weren't improving though. So social support. If he wasn't around, it would have been awful. He gave physical support, but also enormous mental support. So this was the case for most people. Social support was really important, but it's not just as simple as ticking a box. There was one gentleman in particular, I remember, who said, oh no, I always wait till my wife's gone to work because she says I'm doing it wrong and she tries to tell me to do it this way and, we end up arguing. So for him, social support was not an enabler. Trust in the therapist. So time and time again, this came through. So what we say and what we do in our relationships with our stroke survivors is really powerful and really important. And, we need to think about that when we have those interactions. So whatever someone says to me, I just do it. The face-to-face contact, as I said, for most people, this was really valuable. So they found it valuable in terms of being able to modify their exercises, being able to progress their exercises, being able to troubleshoot issues they were having. But for many of them, if you think about the fact that we know that many of our stroke survivors are isolated, it was just being able to chat to people and have a laugh and interact with other patients. So it was often that social isolation that they really loved coming into the hospital and seeing the therapist. Feeling accountable. So when you give your word for something, people are going to rely on you. You can't let people down. This came through time and time again. So, I've said I'm going to do it and I'm not going to let you down. And that feeling hopeful. So this was vital. So, I just kept going. Even I know it wasn't getting better, but I just kept going because I kept hoping that, if I kept at it, then I'd get some sort of benefit. It would pay off. And again, this concept of being committed to the word. So this lady, I think she said 4 or 5 times through the interviews, my word is my bond. In other words, I've told you I'm going to do it. I've signed up and I'm not going back on my word. So I think this is really important and really, talks to issues such as the behavioural contracts, which are used so much in the constraint-induced movement therapy, because if for many of these stroke survivors, if they said they were going to do it, they were going to see it through. Other enablers, being motivated by others. So the clinicians on the Intense trial were supported with some training on motivational interview principles in order to support self-efficacy and make sure people understood the awareness of the importance of adherence. So that was important from the health professionals, but also family and friends helped motivate. Trusting the therapist, as I've said already, but also the research process. I remember someone saying, well, you're all very clever and you've come up with this 10 weeks, so there's got to be a reason for it. So I'm just going to keep going and I believe in what you're saying. So the ultimate, the belief of the ultimate payoff. The attitude to exercise, as I said earlier, many of them were just so persistent, but also some were more saying, well, what have I got to lose? Nothing's happened so far. I may as well just give it a go. How they structured the program. So the nature of this program, which was sort of self-directed, meant that they could fit it in around their day. So many of them would say, I get up in the morning and I'd only want to do half an hour, and then I'd do half an hour later in the day. And many talked about having it as a routine part of their day. So routine practice, same time each day. They might use an alarm or something like that, or just do it at the same time each day. So it became more of a habit. As I said earlier, all of the participants in the Intense trial were asked to record the amount of practice they did. And people describe that as making them feel accountable. And one of them also said, or a couple of them actually said, you know, I knew that you were going to check it when I came in, so I didn't want to be embarrassed. So that, again, it talks a bit to accountability. And having the goals in the back of their mind. So many of them talked about, oh, when I want to play, I want to play golf. And so when I was doing those stretches, I was thinking about my golf swing. And I'm sure many of you listened to Amanda's presentation last week, which was so fantastic on goal setting. And I just pulled that little quote out from her, motivated by the dream, because I think that was just so lovely. And certainly that's what people were saying to me. Annie, I'm hoping you're still there, even though I can't see you. I was thinking a good spot to pause if there's some questions.
Yes, it will be. There's one question that I'll keep to the end from Claire, which is about seeing people 3 or longer years post-stroke and the pros and cons of that, and do people change? So let's keep that to the end.
Yeah.
Somebody's asking about the GRASS program, and is there any evidence that it's showing benefit for people many years post-stroke? And to my knowledge, it hasn't been used with a chronic population.
No, not that I'm aware of. There's quite a bit of evidence to say that it works, and that they also did a study where they specifically looked at whether it worked in the home environment with positive results. But I don't know if I'm not aware that it has been tested out in the chronic. But I mean, a lot of the concepts are around, you know, practice and repetitions as well.
Yeah, for anybody who doesn't know the GRASS program, it's freely available from the University of BC, I think it is, in Canada.
Yeah, British Columbia, yeah.
And it really was only ever tested in one trial by Janet Eng's group, and then it was implemented by Louise Connell in England.
Yeah.
But it hasn't been replicated as a randomized trial, as far as I'm aware. But that was a good question from somebody. But it's certainly worth trialing because it's easy to give to people as a program. It's got 3 different levels. The next question is, why do you use different behavior change models to develop your interview guide and then to analyze data? So that's a good one from a...
That was a really good one. To be honest, it was probably more a matter of timing than anything. So, you know, developing the interview guide was quite early on in the PhD. And that's when I was starting to look at behaviour change models, and this one had been used, the trans-theoretical model had been used in a number of studies as far as coming up with questions. So it was really more of a guide to develop questions that were reflecting enough about people's behaviour. So it is a good question, and, you know, for consistency, looking, you know, if I'd had this knowledge earlier on, maybe I wouldn't have used that model, but it worked well for what it was. It was probably more just a matter of timing. I mean, there are so many behaviour change models, and this might not float your boat kind of thing, but I've looked at a few of them, and I looked at quite a few of them in my PhD, and my personal experience is this one is kind of a simple starting point. So yeah,
and what it does do is it helps you make sure that you've thought about all the possible barriers and enablers, because there's a tendency to think about skills and knowledge as being one of the things that you have to target when you're doing an implementation project, or in something like this, you might be thinking about particular things that are barriers or enablers for people doing their exercise. But using a framework or a model allows you to tick off all the different things that you should be considering.
Yeah.
Another question here is there a particular scale to document motivational change in rehabilitation? And I think there are. I just don't know what they are at the moment.
Yeah, you probably know that more than me, Annie. I'm not.
There are a couple of scales looking at motivation. Simone's online, she might know, because there have been some trials looking at ways to improve motivation in rehab.
Yeah.
And then a final question there is, I'll let you answer this and then I'll put my comments in, is, do behavioural contracts really work in rehabilitation settings?
Well, certainly if you look at the CIMT literature, yes, as a package of care, probably not just by themselves, but I know in the CIMT literature, and obviously Annie and Lauren are the queens of that, it's a model, it's not just by itself, it's a package of care with other components as well around other behavioural components. So certainly evidence would say yes, they do. Maybe not in everyone, but certainly there was a large number of these patients who constantly talked about that accountability.
Yeah, I think it's not, contracts are not used much outside behavioural, outside constraint-induced movement therapy programs, but it's certainly if you're embarking with somebody for an intensive program of rehab, whether it's in the private or the public sector, it's a good thing to use. And the behavioural contracts are very easy to find on the internet. If you go to the StrokeEd website under resources and the CIMT workbook there, you'll find a behavioural contract in there. And we talked about this, Lauren Christie talked about this in her CIMT lecture. So I might let you continue. We've got a couple more questions, but we'll come to them in a little while.
Okay, so we've sort of done the qualitative study, explored the barriers and enablers, and really I sort of thought, well, what now? I mean, there was some really interesting information, there's some really, deep stories and things that I thought would be of value for the health professionals working in our health service. So sort of thought that we would like to develop some sort of resource that they could use. So what I did was went back to the behaviour change wheel and looked at what were the modifiable barriers that we'd found, and then went to the behaviour change wheel to develop some strategy, practical, pragmatic strategies that people could use to address these. And then from that, we actually worked with a graphic artist, and I put up at the start of the presentation the infographic that we developed based on all this information. So when using a behaviour change intervention, there's 3 main steps. So stage 1, understanding the behaviour. Well, we'd done that because we'd done this in-depth qualitative study. We'd done 20 interviews. We've synthesised it and done our thematic analysis using the COM-B model. So we knew what our barriers and our enablers were. Stage 2 relates to identifying the intervention options or the behaviour change functions. So if you remember, that's the red ones around here. So what are the broad categories of actions that we can take to make a positive change in terms of those barriers and enablers? So that's what we did. We went to the behaviour change wheel, and we looked at what were the intervention functions that were relevant for the particular barriers and enablers, and then we developed practical strategies. Stage 3 excuse me, is around identifying the behaviour change techniques and also the mode of delivery. But that wasn't really in scope for this study. If you were, for example, doing a broad scale implementation of an intervention on your rehab ward, you would probably go through this whole process because you'd need to be considering the whole theoretical framework. But for the project, which was about developing a pragmatic tool, this wasn't necessary. So talking through some of these behaviour change functions. So I like this little diagram. So you can see here that they've got definitions for each of the 9 different behaviour change functions. And it may be that for one behaviour change project or intervention, you might use 2 or 3 of these. It's not just one per project. So there's obvious things like education. You might make a pamphlet or do a poster. And you can see the other definitions there. Coercion is creating expectation of punishment or cost. So an example of that might be something like, if you think about when they talked about they'd be issuing fines for people that breach COVID regulations. So we're trying to get people to not breach COVID regulations by coercing them to not do it. So these are the sort of the broad categories that we can use in order to address the barriers that we've come up with. So just an example of how we did that. So first of all, the first barrier, for example, challenging exercises. So the factors to consider. Does the person have the physical ability to perform the exercises? So the relevant behaviour change function that we chose was enablement, one of them. And the specific practical intervention strategy we came up with was to modify and individualise the exercises to ensure the person can perform them. It sounds so obvious, but the feedback that we were getting from these interviews was that wasn't always the case. In relation to opportunity physical, does the person actually have an appropriate space to set up and perform their exercises? So the relevant behaviour change function was the environmental restructuring, the specific strategy, perform a check of the environment in person or via telehealth. And then another example for motivation. Does the person have adequate strategies to make it part of their routine? Again, enablement is probably the most relevant function. Utilise support strategies, for example, diaries, phone prompts and alarms. So this is the process we went through back at the behaviour change wheel. And then I worked with a graphic artist and came up with this great infographic. Now, obviously, you can't read the details there. I have shared this with Annie, so it hopefully will be on the resources on the StrokeEd website. And that infographic was featured by the Australian Physio Association on Twitter and Facebook during Stroke Week in 2020. So what's my challenge to you? Think about what factors do you consider when you design home exercise programs for your stroke survivors? Do you consider individual factors and potential barriers? And do you consider strategies to maximise adherence? So, you know, do you actually really think about that when you design into your exercise programs? Or is it sort of a last minute, oh, I'll get you to do this when you go home, not really thinking through, well, actually, what is the practical side of it? Can they actually do that? Can you work with them to think about, well, this is a barrier, so how about we do this? And the evidence actually says that there are some evidence saying that approach to exercise prescription is often atheoretical. And this paper by Louise Connell, they did surveys with UK OT and physios who were prescribing about prescribing upper limb exercises. So when they asked people, do you prescribe exercises for self-directed practice? Many of them said yes, a few said no, and 13.5% said, well, depends on things like cognition, family support, and motivation. Another finding that they had was particularly related to the inpatient environment, that often exercises were prescribed in an ad hoc manner, mainly relying on verbal communication to the stroke survivor or their family. So yeah, I think that's a bit of a challenge to you, is just to make sure you're really thinking through how you can get them, how you can develop and prescribe exercise programs which are more likely to promote adherence, and therefore if people are doing more, we're hoping that they have they have more benefit. So take home messages. So a sense of hope is important for maintaining motivation. So I'll often hear students say, oh, you know, I was really worried, I didn't want to give them false hope. But, you know, hope is what drives motivation. So it's not up to us, and Amanda certainly talked about that last week in terms of the goals. It's not up to us to take that away. So we need to get skilled at delivering information in a way that gives hope for a positive outcome, but still is in a realistic way. That's a challenge. The therapist relationship. So many of the participants really valued the time that they spent with the therapist. I mean, the therapists in this study were highly experienced. So I think the mean time working with stroke survivors was 13 years, and I think a third had done post-grad training. But you know, this message of, you know, it was really important what the therapist said, and that relationship was really important. I've said a couple of times around the timing of this sort of intensive program, if it's too early and they may have too many other things going on, will they adhere? But if we leave it too late, as the results of the intense trial have shown us, maybe we're missing that window of opportunity. Use of contracts, we've just sort of talked about that. So that can certainly, for some stroke survivors, work really nicely at you know, promoting that kind of accountability. And consider how much support's available. So not just do they have support, but who is it and what can they do? So, you know, if it's a adult child that's the support person, but they've got little kids and they're picking them up from kindy and they're trying to do their own cooking and as well as look after mum, do they actually have time? Like, are they willing and able to help? So it's not just a matter of, yes, they have social support, but what is the level of burden? So those are the main take-home messages. And in conclusion, stroke survivors can undertake a large amount of independent practice when key support strategies are in place. And findings can be used to develop exercise programs that target these relevant barriers and enablers to maximise the amount of uplimb practice undertaken. So that's a list of the key references. So you can see the Natasha Lannon there, that's the Intense trial paper. And I have got a link to the paper, my paper that I've just described, but this is it here, just that 4-letter word, hope.
Thanks, Tam. I'll get you to leave the references up for a minute while people can have a look and take a screenshot if they like. A few questions here. Somebody's asking about managing hope during the study and comforting patients when they didn't receive as much progress as they had expected. Perhaps for many people that would have been a big commitment, and perhaps they didn't get the results that they hoped for.
Yeah, it's a really good point, and that did happen. Most of them still maintained a positive outlook, which was quite amazing to me. I do remember one gentleman in particular that kind of really dropped the bundle. So he was dead set sure he was going to get a really good outcome, and it was very clear he wasn't going to quite early, and he actually became quite depressed. So they're challenging conversations, and I think, you know, certainly when you're working with students, they have a lot of trouble with those conversations, and I think we get more and more skilled as we get more experienced around those. But I mean, often we'll say to people, you know, the biggest thing that you can do is keep trying, you know, and as I said, keep hoping. And, you know, we don't have a crystal ball, but the more you try, the more likelihood that you will have some positive change.
Yeah, and I think if you've got people who are several years down the track, this sort of gets to Claire's question, is about people 3 years after stroke, and is it appropriate to expect hope? And I think it's not our job to decide if somebody wants to work on their arm. If they have goals around their arm recovery, perhaps giving them a limited period of time that they're going to work on things, and have evidence-based interventions like that were tried in the Intense trial, and people try that for a period of time, and you've got measures at the beginning and the end. And then at the end of that time, you know, and they know that you've tried all the evidence-based interventions that might help to elicit movement or to help them improve recovery.
Totally agree. And that there is also some trials, Claire, that have looked at a chronic population. So I'd draw your attention to Nick Ward's study in the Queen Square group from England. So I've actually got the paper right here in front of me. So intensive upper limb neuro rehab in chronic stroke survivors, chronic stroke. So the practicalities of this study are probably not very practical for us to apply in many of our health services, because they literally did 90 hours in 3 weeks. So they did they did 6 hours every day for 3 weeks. But they found that this population, which was chronic, did improve, and they maintained their improvement at 6 months. One of their exclusion criteria was around severe spasticity. So it's a different group. They're chronic in terms of time since stroke, but they probably don't have, you know, the secondary contractures and other issues we were dealing with in the Intense trial. So I think, I think, you know, I think that whilst that window opportunity for the big changes is obviously early, studies like this one by Nick Ward certainly show that it's not a lost cause down the track in a more chronic population. Yeah.
Do you want to put your last slide up there, just in case people want to see your contact details, and then you can perhaps take the slides off. For anybody who didn't catch that, that's Nick Ward, W-A-R-D, from the Queen Square program, and it is an NHS funded program. It's not a private program, so it's not impossible. And the participants in that program didn't all do one-to-one therapy for the whole of the program. They did do some work in groups, so it's worth having a read of. If you could stop screen sharing.
Sure.
Thanks, Tam, and we'll go to the last couple of questions. Did people have support from therapists with their goal setting to ensure they were smart?
Yeah. So they used goal attainment scaling. So when they basically, as soon as they were randomized, they did goal attainment scaling with the research, as the person that was in charge of the research side of the study.
Okay.
Yeah, and that was for the control group as well.
Yeah. And it's worth listening. If you haven't listened to Amanda Baker's talk from last week, that's a good recording, because there is some discussion and some doubt about the relevance of using SMART goals at all anymore.
Yeah, well, especially the A part of them. Yeah.
Another question here was confidence in their ability to carry out the exercises without the therapist present, something that affected their adherence to practice.
Yeah, I'm sure for some of them it would have. I guess that they were very well supported at the top end of the study. You know, they came in twice a week. So that was probably for the first couple of weeks from memory, and then they came in once a week for a couple more weeks. So they were well supported, and in those sessions it was really about problem solving, working out other ways of doing things. So they might have struggled at times, but they generally were quite well supported.
Okay, thanks. Going back to the behaviour change wheel by Susan Mishi and her colleagues, is there an interview schedule for the behaviour change wheel?
So I have got on the reference there, the behaviour change wheel guide. So that is an unbelievable resource if you can get it. It's over 300 pages. And within that, there is a number of surveys and interviews which are based on the models, the COM-B model, and also the TDF, the Theoretical Domains Framework model, which is also discussed in the guide. Yeah,
and there's quite a few publications that use the wheel,
absolutely,
their guides as an appendix.
Yeah.
At what scale do you think, with robot-assisted rehab, the behaviour change model could be applied? It could be applied with any intervention, really.
For robot-assisted. Yeah. I mean, anything where you're looking for a change in behaviour, I think it can apply to any therapy, really. Yeah. I guess it depends how, you might be formal or you might be informal with that. So, I guess what I mean by that is that you might be doing a formal behaviour change or an intervention implementation study, using it in a more formal sense. But, often in my head now when I'm with a patient and thinking about what I'm doing with them, I'm thinking about the COM, because it's so easy to think about, those three factors. So I think you can apply it very easily in a very practical sense. Yeah.
Last one here is, are there any easy apps that clients can use to track their adherence or their home program when they're alone?
Well, I mean, if you look at things like PhysiTrack. So PhysiTrack is an exercise platform that we use a lot at work. So, and that has an adherence component to it. So as a physio, I can actually, if we're using it properly, they've got Physi app on their phone or their device. I can actually see what they've been doing. So there are certainly apps. I don't know, maybe, do you know any of in the OT world, Annie?
Well, most of the apps tend to be generic rather than specific, although there are more physio apps than there are OT apps. The physiotherapyexercises.com is one that I'd recommend because it's free, and that's one that Lisa Harvey and Sydney developed. So it has pictures and diagrams that you can use in somebody's home exercise program for upper limb or lower limb exercises, stroke and spinal cord injury and brain injury. But it also has an app for your phone, and you can get people to record their repetitions and their not their repetitions, but their practice, and you can set that up for one that you can monitor as well if you want to off-site. So that's physiotherapyexercises.com, which is free and available in many different languages as well. So I think that probably brings us to the end. We're a little bit over time, so I might close off the questions now. There's lots of people saying thank you very much for a very good session, and I'll close off the recording now. And say good night or good morning to everybody who's leaving
Yes.
us from the European end.
Thank you. Thanks for listening, everybody.
Thanks for taking your time to prepare this for us, Tam.
That's all right. No worries. Thanks, Annie. See you.